Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we do get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss snoring, a problem that affects nearly 50% of Americans at some point in their lives. While for most men, snoring is an annoying problem that can put a strain on their relationship, for some men, snoring can be a sign of sleep apnea, a much more serious condition that can have significant health consequences. So how can you tell the difference between snoring and sleep apnea? And what can you do to prevent snoring and treat it when necessary? In order to help us answer these questions, we turn to a true expert. Dr. Eric Kezirian is a clinical professor of otolaryngology at USC. Dr. Kezirian earned his medical degree from the University of Pennsylvania and then completed his residency training in otolaryngology at the University of Washington. He then completed a fellowship in sleep surgery at Stanford University. His research has addressed the most important questions in the field of sleep medicine, including how surgeons should choose procedures, how well surgery works, and the development of new treatments. Dr. Kezirian's research has been supported by the National Institutes of Health, the American Academy of Otolaryngology, the American Academy of Sleep Medicine, and the Triological Society. He is a past president of the International Surgical Sleep Society, the world's premier organization dedicated to sleep surgery. And now, I bring you our conversation with Dr. Eric Kezirian about snoring and sleep apnea. Hello and welcome to the Better Man Clinics. Today we're going to be talking about snoring, a problem that affects a lot of men in this country and around the world. In fact, a recent study showed that about 45% of all adults snore in this country and 25% of people snore regularly. Now, as we know, men tend to snore more frequently than women. And for most of those men, snoring can be a nuisance or an inconvenience for either themselves or their partners. But for some men, snoring could be a sign of a much more serious medical condition that could really affect their health significantly. So to help us sort through all this, we are so lucky to be joined today by a true expert on the subject. Dr. Eric Kezirian is not only a professor of otolaryngology at the Keck School of Medicine at USC, he's also one of the world leaders in surgery for the management of snoring. Dr. Kezirian, welcome to the program.
Oh, thank you so much. I really appreciate it. Nice to join you all.
Thank you. We're really looking forward to it as well. We have tons of questions to ask you about this very important and very common problem. So, but before I do, I actually want to take a step back. One thing I like to do is just to learn a little bit about you. And one question I have is, what inspired you to follow the path of otolaryngology and specifically the path of being one of the world's experts on the management of snoring?
Well, it actually goes back to medical school for me. And we were a little unique back in the dark ages when I went to medical school. It was one of the few places in the country at that time that incorporated obstructive sleep apnea and sleep disorders in general into the curriculum for the first couple of years, which was the classroom part of medical school. Mm-hmm. And so I was fascinated by sleep disorders, thought that I could empathize with someone who got a terrible night's sleep. And so we actually went to the sleep center then, and it was, again, a long time ago, it was just at the point that they were still doing these tests at night called sleep studies that mm-hmm. now are all computerized. All the data comes out and you look at it on the computer screen. But at that time, it was the old-fashioned, huge pieces of paper that had the feet, like printer feeds, and they were papers with all these squiggles on them, and they were circling. These squiggles look abnormal and this and that. And I thought, just knowing my own personality, that wasn't going to be something that I really would want to sort through a whole stack of papers and flipping over one page at a time for every single patient. So I thought, well, that's really interesting, but maybe not for me. And then we actually had otolaryngology as part of the required for every medical student required for a week. And I thought it intrigued me, and there was a lot of variety in the field. And so I did it a full month later on. And I met someone who's now a good friend of mine, was, a mentor and all that. I was doing a sleep surgery case. So it's a patient with obstructive sleep apnea. And I said, I had no idea that this was even an option for patients. And you told me that, of course, for people that didn't do well with non-surgical treatment, this was something that was an option for them. And I asked him, so how well does it work? And he said, oh, not very well. And so in my mind, I thought, there's this really common problem. You have a lot of people that do great with non-surgical treatment, but when you think about surgery, I thought, we could do better. And I always figured that I would be doing some sort of research in my career, just, hoping to advance the field, whatever field I chose. And so anyway, it really resonated with me. And I actually applied to otolaryngology residencies thinking I would go into sleep surgery as one of the two possible areas of focus. And it was really unique because there were only literally like 3 or 4 people in the country that were really doing a lot of this at academic centers. Anyway, so it all, I took a couple twists and turns, had a few changes of heart back and forth, but anyway, this is where I ended up, and it's been great. And it's been nice to see we have a growing number of people in this field around the country that are really, moving the needle. And we made a lot of progress in the last 20 years that I've been doing this, made a lot of progress, and it's really, building on the shoulders of my mentors, and who are still, many of them still, obviously doing this, but hopefully we've got a critical mass now. We've been able to make some real improvements.
It's so great that you're doing this because, again, with snoring, obviously, you hear the jokes about snoring, and get somebody throwing a shoe at them and stuff, and it could be funny. But for a lot of people, it's very disruptive, and it's such a common problem. Now, jumping into snoring, let's start at the very basic level. Everyone knows what snoring sounds like, but what is snoring? What's actually happening to make those dreadful noises in the middle of the night?
Yeah, well, I just want to circle back a little bit that, what is snoring and why, how do we define it? And there's this great saying that I did not come up with myself, but that snoring is in the ear of the beholder. And we're talking, basically we're talking about we're plain old snoring. It really, matters if it's bothering someone else. And you obviously already mentioned that, but it's something that it means differently to different people. And sometimes it's just something as simple as just heavy breathing, that we wouldn't really think of it as the true snoring. But when we're talking about, true snoring, for lack of a better word, it's vibration. That's what creates sound everywhere, is vibration. And so the snoring that occurs is vibration, typically of the soft palate, which is the roof of the mouth, the back of the roof of the mouth, typically of that, but not always. And, obviously patients, there's more and more opportunities for people to record snoring, either a bed partner's phone or somebody's own phone. There's a lot of apps out there that can record snoring. So everyone always wants to play their snoring for me, but it's something that it is different in different people. The most common thing is that soft palate vibrating, but other structures can vibrate, especially the sides of the throat, sometimes can be a big source of the sound.
Got it. And so that leads actually to my next question. Is snoring caused, real snoring, the ones that are the top, the gold record type of snoring, not just the ear of the beholder, but true snoring, is that all caused by the same problem, or are there multiple causes in people's lives that could be causing snoring potentially?
Well, if it were that simple, then surgery would have worked 20 years ago, and
right.
It'd be perfect all the time. So there are different causes, and the best way to think about it is that air, as you're breathing at nighttime, ideally air is coming in through the nose, going through the throat into the lungs. And when it's smooth, it's smooth, and there you don't get structures that are vibrating as much. But when there's something it's almost like whitewater rafting or whitewater in rivers, that when the water is flowing through there, it just flows smoothly. But you get whitewater when there's something disrupting the natural flow. We call it turbulent airflow instead of airflow, but those are technical terms. The idea is that when it's smooth, it doesn't really create the same sound that it can when there's something that's narrowing the space. So the sound itself comes from these one or two areas, but actually there are many causes. And that's really actually been the focus of my entire career, is how we choose different things, and especially for obstructive sleep apnea, which often has snoring associated with it, but how we choose different treatments for different people, because we need to figure out what's causing it, what's creating that, disturbed, flow of air, what's causing it not to be as smooth as it could be.
Got it. And are there things in terms of people's lifestyle or other characteristics that could contribute to snoring?
Oh, absolutely. I mean, you mentioned, obviously, in men, it's about twice as common as in women, especially women before menopause. But there's the classic factors that contribute to it include the natural aging process, as well as weight gain. Those are sort of the three key risk factors for disruptive snoring and for this condition that you mentioned, obstructive sleep apnea.
Got it. And just looking online, I noticed a couple of things like mention the position of where you're sleeping. Does that impact anything?
Absolutely. So body position, those are what I mentioned before, were the things that are almost unchangeable, or not, I shouldn't say unchangeable, but factors that are the patient themselves that are not going to change on one night. The other things that play an important role include body position, where typically sleeping on one's back is going to be worse than their sides or their stomach. About half of the patients with obstructive sleep apnea, so with full-blown blockage of breathing, not just snoring, but about half of them have a dramatic difference between their sleep apnea and their breathing basically on their back compared to their side or stomach. So that's another big factor. And then the other big thing besides weight gain, which is obviously can occur over time, is alcohol consumption or other sedative different medications. Those basically, they relax muscles and can basically make everything more floppy and more of a setup to have this vibration that occurs at nighttime in snoring, and then of course the blockage of obstructive sleep apnea.
So you bring up sleep apnea. I think it's a good time for us to really define what that is, because there's snoring and there's sleep apnea. They're related, but they're very big distinction between the two. Can you help us understand what sleep apnea actually is?
Sure. So there's actually two kinds of sleep apnea. The most common kind, and the one we associate with snoring typically, is called obstructive sleep apnea. And so it's obstructive, meaning that patients are trying to breathe, but there's some obstruction, there's a blockage that prevents them from getting normal breathing. And so it's basically of at least 10 seconds of either completely blocked or notably blocked, and there's different definitions of it, but basically not getting normal breathing, normal airflow at nighttime, and it can have all sorts of consequences. And so the overlap is that most patients with obstructive sleep apnea, but not all, but most patients will have snoring. And then of course, there's a lot of patients who just snore, but don't have blockage in breathing. So there is this overlap, but they're different. And the way that they're distinguished is if someone has what we call disruptive snoring, which is snoring that's consistent and waking up others, there are signs and symptoms that go with obstructive sleep apnea, they'll want to get a test. And the test, there are different kinds of them. They're called sleep studies, but they'll look at breathing patterns and things like oxygen levels and all that. And they'll differentiate whether it's just plain old snoring versus obstructive sleep apnea. Sometimes people will say, oh my goodness, someone, they're choking and gasping at night. And that's the kind of thing that may happen every night, to be honest, but it usually happens every now and then. What we care about with obstructive sleep apnea is repeated blockage of breathing. That's not always as dramatic or obvious as the people that choke and gasp rare, but if it's happening repeatedly all night long, that's what a sleep study can pick up. Whereas obviously we wouldn't put someone's bed partner make them responsible for making the diagnosis. There is actually a test to figure out whether there is this obstructive sleep apnea problem occurring.
But again, the for a guy or their partner to really start thinking, hey, maybe this is sleep apnea. It's just that you're actually hearing them stop breathing. You're actually hearing them and then gasping for air afterwards, or is it more subtle than that?
Well, it can be a little bit different. And obviously some people sleep alone, so they don't have a bed partner. And so the things that typically trigger concern over snoring and the possibility of sleep apnea, they do include things like a bed partner worrying about you, whether they're not getting sleep or they're just worried about you and you're breathing at nighttime. But they can occur looking at some of the consequences that arise with obstructive sleep apnea in some, but not all patients. But there can be disruption of sleep, so people can feel like they're sleeping all night long and they wake up and they're just as tired as they were, or certainly not refreshed enough. So because what happens is when you get blockage of breathing, you can actually wake yourself up and not even be aware of it. You can just wake yourself up very briefly and unfortunately not get the deep restful sleep that you need. But there could be other consequences. There's with severe sleep apnea, in particular, there's health risks like high blood pressure, risk of some serious things like strokes, heart attacks, and even early death. And so there are some signs and symptoms, we call them, that can make people more concerned and alert people to getting checked out in a more detailed way with these sleep studies.
Got it. And so like the daytime sleepiness is an important one, I guess, because just to be clear, if somebody is just snoring, but they don't have sleep apnea, they're still sleeping through the night, right? Versus sleep apnea, where they may not know they're waking up, but they're kind of waking up. Is that correct?
It's commonly correct. It's a little more nuanced to that, but the basic idea is that people, there is some evidence maybe that it's not totally true, but in general, we've always felt that if someone's snoring, they're probably not waking themselves up, but just maybe waking up someone else. And if they have obstructive sleep apnea, they can often have, significant snoring that they wake up feeling refreshed. They feel great. They're not having, any health consequences, and that can absolutely occur.
Got it. And so you really have to look at kind of symptoms at night, during the day, and really get those hints, because again, as you mentioned, the sleep apnea has consequences that go far beyond just not getting a restful night's sleep. So it is something to be very aware of. And to that point, are there any, for somebody who just snores, are there any red flag signs that they should look out for to say, you know what, maybe I should see a doctor?
Well, it includes some of those things I mentioned. So it's something that if it's consistent, loud snoring, again, there are people that aren't tired from their sleep apnea, so they may not know they have it, and actually can have health consequences. So it's something that if you have consistent snoring that's would be bothersome to others, it probably is worth at least talking to someone about whether you should get this test called the sleep study. But the classic things are the people that are not getting good quality sleep, so they will get enough hours of sleep, typically at least the 7 to 7.5 hours that we recommend, and they're not feeling refreshed. And what I tell people all the time is it's not just, the natural process of getting older. I mean, obviously, we're not 22 years old anymore, but the point is that these things do occur with the natural aging process. They can be treated to help people feel better. And so those are some of the things besides those health consequences that might arise. We usually want to try to catch it before it gets to that point, if at all possible.
Perfect. No, that's very helpful to know kind of when to look for help. Now let's take a step back from sleep apnea. Let's go to run-of-the-mill garden variety snoring. There's a lot out there online and elsewhere and on TV in terms of do this, stop doing this, buy this, things that you can do either through lifestyle modifications or purchases in terms of helping limit snoring. What are your thoughts on that? What actually in your mind works?
Yeah, so it's a little bit of the Wild Wild West, especially when it comes to snoring without sleep apnea, because the FDA rightly does not consider it a serious medical condition. And so basically people are getting clearance, which is a very different thing from FDA approval. They're getting clearance that they can market things for snoring. And so there are some things that are probably helpful in certain patients. But of course, the marketing doesn't, try to limit it. The marketing is just a little bit of a, shotgun approach saying everyone with snoring come buy our product, which is, again, these things are safe, but they're just not, it's sort of going to be a waste of money for a lot of people. And some of the things out there, and part of this is seeing someone that can help guide you through what might make sense for you. So something as simple as breathe right strips or other things that go on the nose to help you breathe better through your nose. And there's various ways to try them. They're certainly very safe, but it's something to try them to see if that is a big part of it. And you just sort through the pattern of your snoring, basically, of saying that when my nose is blocked, my snoring is really bad. Well, let's try to fix your nose being blocked. And if it's something that, in this case, when you breathe in, the sides of your nose collapse, well, then doing something that directly treats that would make a whole lot of sense. And so it's something that I certainly don't recommend it for everybody, but I definitely have a lot of people that get nice results with snoring with something as simple as that. There are other things out there that have been tested, actually. And one of the things that's a little bit tricky about snoring is it's not something that has a ton of great research, because it's something that hasn't really been measured as clearly. For example, if you have a microphone that's close to someone versus far away, the snoring will just be louder if it's closer. And so it's a little hard to do great snoring research. But there have been everything from all sorts of throat sprays to, we were just having, part of an article looking at certain exercises for the tongue and trying to snip the area underneath the tongue to try to help your snoring. All this stuff is pretty much unscientific, and it can be actually pretty expensive. I mean, thousands of dollars. And it's something that you just want to be careful and seeing someone that really does this and asking them How do we know that this is actually going to work before we do things? I mean, there are various pillows that can help in certain people. And certainly some of the simple things that we've talked about of avoiding sleeping on your back, that there's everything from make it yourself, wear a t-shirt to bed when you sleep and have a pocket sewn on the back of the t-shirt to fit a couple of tennis balls. It's something that's been around a while, and it's something that sometimes people just sort of give up on it. But if you wear it and it keeps you on your side and not on your back, it can actually be very helpful. And there are various products that are being manufactured because people don't want to try to do it themselves. So there are things that are available, whether online or in stores. But the point is that you can make it yourself and try these things out. And honestly, it's all a part of looking at the patterns and talking to someone, a bed partner, to say, well, when I'm really snoring, am I sleeping on my back, for example? And they say, absolutely, my sharp elbows. But it's something that I'd rather not have to wake up with the sharp elbows. Maybe that teacher with tennis balls or something similar, using special pillows, either in front of you, behind you, they can maybe achieve some of the same goals and do something simple to get the snoring to clear out.
That makes sense. So it seems like sleep position is a big one. You had mentioned before weight loss, right? So, or I mean, not weight loss, but weight contributing to, so I assume weight loss will help in some people?
Very much so. Now, a third of the patients, even with sleep apnea, are not heavy, not overweight or obese, but weight loss in people, it's again this pattern of, well, I gained 10 pounds in the last year or two and my snoring has gotten really bad here. Well, that's probably losing that 10 pounds is going to make a huge difference for that person.
Got it. And another thing you mentioned in terms of causation was about alcohol and sedatives. Is there a time period between where you can, let's say, have a glass of wine and go to sleep where that might wear off so it won't have such an impact on snoring for you?
That's a great question. So my typical recommendation is to think about it a little bit like driving, actually. So not just being under the legal limit, but really having it clear out of your system. So typically I tell people, you don't have to stop drinking alcohol entirely if you enjoy that, but try not to drink after dinner, ideally basically 3 hours or so to have everything clear out of your system. And it turns out alcohol is really bad for sleep, although you do have a drink before dinner because it helps them fall asleep. Problem is the sleep quality is crummy. It prevents you from getting good deep sleep, and people wake up more and have a harder time falling back asleep. It's actually been shown with some research. So typically it's let it clear out of your system by not drinking anything out after dinner. And so about 3 hours to let it, again, clear out of your system.
That's a good rule of thumb. Another thing that I saw that I'm not sure the relation with, I mean, smoking is bad, period. There's no need, that public service announcement we're clear on. But I saw somewhere a little bit of research in terms of smoking cessation can help with snoring. What's the mechanism behind that?
Yeah, I think there is, again, the research is hard to do, but certainly asking people about their snoring is probably the way that most of these things are studied. The mechanism would be basically snoring such an irritant. So it causes irritation and swelling inside the nose, which the nose makes airflow less smooth, and probably also irritates the throat, of course. And it's something that the throat is a little more open than the nose, but it's probably bad on both areas as far as being irritation and swelling.
Got it. And then the last thing in terms of lifestyle entrepreneurs is kind of interesting. It's kind of chicken and the egg. They were saying that if you don't get enough sleep, you snore more, and then you get less sleep and then you snore more. So how does that play in?
It's not clear, but typically people say that, and the mechanism that's most likely is that people that are sleep deprived or have any other sleep disturbance, they're going to want to go into deep, restful sleep a little bit more. And for longer periods of time, just because they're trying to catch up. And so those are the times like rapid eye movement or dreaming sleep. There's other kind of deep sleep called slow wave sleep, but they have basically the muscles are more relaxed during rapid eye movement sleep. And so you have your eyes are moving. That's why it's called rapid eye movement, but the rest of your body is very relaxed. And so if you think about it, your throat is almost a tube for breathing, and they're surrounded by muscles. And so when the muscles are extra relaxed, that's just more that can collapse and block breathing, more likely to have collapse and block breathing or contribute to snoring itself.
Got it. No, that actually helps explain it quite a bit. And in terms of the non-prescription devices, you mentioned nasal strips, but you made a very valid point in the sense that nasal strips only work if the blockage is in your nose. But if it's anywhere down, that's not going to necessarily help. Is that correct?
Correct. And so people can look in the mirror and just breathe in. And basically what they'll see is not on the highest part of the nose where we have bone there, but the areas that are a little lower down, almost in the middle part of the nose, that the sides are caving in, not with aggressive breathing, but just normal breathing. The sides are caving in. well, that can be really helpful. To something like a breathe right strip, or the ones that slide inside the nostrils and can keep the nostrils open.
And the latter those are the nasal dilators. Is that correct?
Correct. And there's a whole slew of them out there.
Got it. But again, I always caveat this, it depends on the patient and there are conditions, but generally speaking, there's not a tremendous harm to trying those to see if it helps and stuff like that.
Oh, very, very safe. I mean, there are probably some people where it might cause irritation and potentially a little bit of bloody mucus. And if that happens, you would obviously just stop it. Breathe right strips, the adhesive can irritate the skin on the nose. A little more common in women though, just because they typically have a little thinner skin, but it could be
sure.
Men, adhesive allergies, all those kinds of things you'd be concerned about, but not any direct obvious harm for most patients.
Got it. So let's say I tried all of this and you know what? It's not working, or maybe I have some of those symptoms of sleep apnea that we talked about that I'm getting concerned about. And you know what I say it's time to finally see a doctor. Now, part of the reason for this podcast, as you know, men are pretty reluctant to go see the doctor. It's very anxiety provoking to them because one of the reasons is they don't know what to expect at that doctor's visit. They don't want to be caught by surprise. So if I go to you, I've exhausted my options with tennis balls and breathe right strips, and my wife is ready to send me packing for my snoring. What would I expect in our first consultation? What should I expect?
Sure. Well, so the two groups of physicians that people would typically see are in otolaryngology, so that's my field, or in sleep medicine. And those are colleagues. I'm actually board certified in sleep medicine, but they're colleagues in sleep medicine. They can come from all sorts of backgrounds, from big lung specialists or pulmonologists to family medicine, internal medicine, neurology, psychiatry, anesthesia. I mean, there's all these different backgrounds. It's sort of these wonderful fields that have people that bring different perspectives. Mm-hmm. And so what you would say, they'd go through the full, we call the history and physical examination. So they'd say, tell me about your snoring. Tell me what brings you here. And then of course, tell me about your snoring. Do you have these things that we worry about having a more serious problem like obstructive sleep apnea? And often it will lead to a test called a sleep study to figure out whether you have this obstructive sleep apnea. Now, if you see an otolaryngologist, we do a little bit differently because we're used to looking in the nose and the throat, which is sort of the underlying problem there. So we'll open your nostrils. It's something very simple, not painful, just opening your nostrils and peek inside your nose. Use tongue depressors to look inside your mouth. So stuff that's very, basic things, but this is what we do all the time. And so in our mind, we'll be thinking about, well, what can we do? What can we think, something simple or one obvious thing, what obvious things could we treat that would potentially make a difference before we even do this sleep study test? For example, we would look at the color of the lining of the nose. Does it look like you might have more significant allergies that you maybe don't appreciate? Did you have big tonsils? All these kinds of things that we would look at as possible factors that can play a role in having some obstructive sleep apnea, things that you might even start with some basic treatments before you jump into the test to figure out whether you have this problem or not. So nothing's painful, and all some things are simple, but the test could be ordered. Now, when it comes to patients that have gone through things that we're really looking about doing treatments, and certainly when it comes to procedures, we do take a little bit more of a detailed look, and we have these flexible telescopes that we use all the time that can look deeper inside the nose and actually into the throat, just while you're awake in the office. But it is a little tube. We put a camera on the end so we can look around, and it's basically a little tube in your nose. And so we give you numbing medicine. And so it's something that I've had it done many, many times, including doing it to myself. Well, we won't get into that. But the point is that it's something that is done all the time. It sounds awful, but it's actually not so bad. People all the time are saying, you made it sound much worse than it was, because it's like a minute. And again, you're not knocked out. You don't have to be knocked out. It's not like a colonoscopy or a look all the way down into your stomach, for example, but it's something that is really just looking inside your nose and throat just in the office. So that's, again, reserved for the people where you're going to think about doing something more involved. The basics are the basics. And it's something that people shouldn't be worried about it because it's not painful, and it's for just looking in the nose and throat.
It doesn't sound too traumatic based on what you're saying, for sure. A couple of minutes, maybe some mild discomfort. I can deal with that. So let's dive a little bit into this sleep study. I'd love to learn a little bit more about the logistics, what to expect, because that sounds a little bit more involved. It doesn't sound as involved as you were talking about with the little squiggly lines in the paper coming out all night. But can you give us an understanding, like what is involved? Like if you prescribed a sleep study for me, what am I in for?
Sure. So the sleep studies there fall into two main categories, at least the sleep studies that are done for figuring out whether someone has obstructive sleep apnea. The most common kind are done at home. And there's numerous technologies out there. They have subtle differences in them, but it's a relatively simple study where you would get some equipment, could be sent to you in the mail, but typically you go in and pick it up from a center and they show you how to put it on at nighttime. And you wear it for one night, sometimes more than one night, but you basically have, it's a fairly straightforward monitor at night because you turn it on when you go to sleep. But basically it has a sensor in front of your nose and your mouth to look at breathing patterns, a sensor in your finger to look at oxygen levels, and then a belt around your chest typically to click on a little recording unit. So go home, they'll show you how to put it on. You go home, when you're getting ready for bed, you put it back on, you get ready, and when you're ready to fall asleep, actually you press the start button, and then in the morning you press the off button. And it's really, it's still something on you, so it's not as comfortable maybe as a typical night of sleep, but it's pretty non-invasive. It's not something going inside you. The sensors are just in front of your nose and mouth. There's nothing that goes internally. Mm-hmm. That's what's being done as a primary treatment for most patients who are worried about obstructive sleep apnea. Now, the more detailed test that used to be done for many years as the primary, but now is more reserved for a selected group of patients, is done in the sleep center. So instead of being your own bed at home, you're coming into a sleep center. And it's a much more detailed test where you have everything, including monitors on your scalp to look at brain waves, something in front of above and below your eyes to look at those eye movements. So we talked about rapid eye movement sleep, but there's sensors on your legs to look at leg movements, and just you're wired up a little bit more. And you look ridiculous when you do a photo of myself, back in the day when I got one just as part of the experience of finishing up my training. But the point is that it's a more detailed look, and you would not be in your own bed, but nothing's really inside your body. There are some places where they still have potentially one sensor inside the body, but that's not really even done very much. So it's something that most centers, even though it's a little uncomfortable, you got all these things on you, you're like, wires, this, that, whatever contraption, but it's not painful. It's just that, the hope is obviously that you get a pretty normal night of sleep. And sometimes with all the sensors on there, it can be a little disruptive, but that's done for people when they have significant heart or lung problems, or maybe neurologic problems, when there are specific reasons to go through that. And especially with COVID, we wanted to keep people out of the hospital or any facilities. So most studies are being done. And that's been the way it's been for the last 5 years, at least.
Well, that's a lot more convenient to do it at home. And for the home test, are you just still doing one night, or you have to do this over a course of a week? How does that work usually?
It depends on the center. Most centers are doing one night. We at USC, the center happen to do 3 nights, because what will happen sometimes is one of the sensors will become displaced or something like that. And so you might not get great data, but you don't necessarily need perfect data all night long, but it's a little bit less of, we call it test failure, if people have more than one night. And I work with a bunch of centers all over the place, but it's something that at the sleep center at our institution, they happen to do 3 nights, but one night is not wrong. It's just that there's a chance that you won't collect enough data to really get a good information.
Got it. And just to be clear, and you may have mentioned this before, but I just want to be crystal clear. The sleep study, is that basically in a binary fashion telling somebody if they have sleep apnea or not, or is it looking for other things as well?
The home studies are primarily whether you have obstructive sleep apnea or not, and really how bad is it. It's actually important as well. Whereas the in-laboratory tests, they're a little bit more detailed. They look at not just do you have obstructive sleep apnea or not, but they look at the other kind of sleep apnea called central sleep apnea. They look for leg movements. They could even sometimes pick up even seizure activity in some patients. And there's ways that you do it a little differently if you're worried in advance about something like seizures happening at nighttime. But the point is that it's a much more detailed. There's all these monitors on there, and that's where you can get a little more information. And you use them sometimes if you're worried about other kinds of sleep problems.
Got it. And when you said for the home test, in terms of how bad the sleep apnea is, so is that based on how many times you stop breathing, how low your oxygen levels go? What are you looking at to gauge the severity of the sleep apnea?
Sure, that's a great question. So there is a certain amount of blockage in breathing that is within the range of normal. So for young middle-aged adults, up to 5 times per hour, so it's a lot of times, of some blockage in breathing is considered within the range of normal. And it's actually very frustrating, going back to this choking, gasping. Somebody will say, how can you say I'm normal? I'm told that I snore and choke and gasp a couple times a week. It sounds awful. Well, the idea is that it's not, it's still worrisome, don't get me wrong, but there's a certain amount of blockage of breathing that can be within the range of normal. But we have these ranges of mild, moderate, and severe obstructive sleep apnea, whereas mild is 5 to 15 times per hour with blockage breathing. Moderate is 15 to 30, and severe is greater than 30. And it's the reason why the difference is important is because the health consequences of obstructive sleep apnea are mainly in those with severe obstructive sleep apnea. Sometimes those patients aren't tired, actually. They're not having that waking up every night, but they can have things that are really can be serious from a health perspective.
Yeah, that's the scary part. They don't even know something's going on, and it's building up behind the scenes.
Right.
Aside from, so again, this has actually been very helpful. So you understand, okay, this is what I'm going to get in the doctor's office. This is the sleep study. Is there any imaging tests, or are there any imaging tests that we should be anticipating as part of the evaluation?
Other than that telescope look that we do, and especially when someone's thinking about surgery, so usually not on the first evaluation, but that little telescope going through the nose into the throat, imaging has not proven to be helpful as far as guiding treatments. Mm-hmm. So there are CAT scans, MRIs that are mostly in the research settings and can be done when people are thinking about something like jaw advancement surgery. So breaking the jaws and moving them forward, which is one of the options that exists for sleep apnea. But it's not by and large a typical thing done for the average sleep apnea patient.
Got it. Okay, so we've gone through the evaluation. We've maybe done a sleep study. We've gone through the camera. You have all the information you need. You say, Oleg, you know what? I know what to do for you. Let's dive into that a little bit. I'm going to throw one thing out just to get out of the way because everyone's going to ask, right? Is there a pill I can take for this?
Unfortunately, not right now.
Fair enough.
people are working on that, and including us, but some of my colleagues in Boston, and they've shown some encouraging results. The problem is the medications that have shown a little bit of results have pretty bad side effects, especially in the people that we're treating. So they're not ready for usage yet.
Got it. Fair enough. I had to ask because everybody's going to ask that question. I can't just take a pill. Come on, man. You gotta give me a pill, doc. So
right.
Let's say there is no pill. I'll take your word for it, right? And so now, I know that if you look online, there's a litany of different procedures and treatment options, from devices to surgery to some combination of the two in terms of treating either snoring with or without sleep apnea. Can you help us break that down a little bit in terms of even buckets? Like, how do we think about this?
Yeah, I think the buckets analogy is a great one. So I have the same discussion with all my patients, and that there's 4 main categories of treatments for obstructive sleep apnea. The first category is some of those conservative things that we mentioned. So avoid alcohol within 3 hours of bedtime, lose weight if you can, if that seems to be a big part of things in particular. And oftentimes, by the way, we do weight loss, do the things in combination. So weight loss can be while we work in other areas as well. And then positional therapy, which sometimes just makes things better if you stay off your back, but sometimes could clear it up completely. So that could be an option all by itself and work on its own. Mm-hmm. In my practice, the first line option beyond those is what's called CPAP, or positive airway pressure therapy. They're different, I guess, technically different approaches, but the most common one is called CPAP. Mm-hmm. And it's really had some nice advances, not so much changing in the last 5 years, but certainly compared to where I started out. The main approach with CPAP, the main technologies that we use it's called automatically adjusting CPAP. And the way it works is the algorithms have improved and the ability to deliver CPAP that responds to a patient. And the reality is that some patients need different amounts of CPAP pressure during the night, and the machines work well. And CPAP, the underlying mechanism is that it's basically an air blower. It's not that sophisticated, but it's an air blower that sits on your nightstand right next to your bed, and it blows air through a tubing to a mask, either over your nose and mouth together, or sometimes tucked a little bit inside your nostrils. And you have this tubing that comes off, and it delivers this pressure, and it's almost like a balloon, ballooning open to your throat a little bit. So you don't collapse, which is what obstructive sleep apnea is, and it keeps the throat open for air to come in and out. And so different people need different amounts of air pressure, different amounts of ballooning. Some people, it just opens up with a little bit. Some people need a little bit more oomph behind it with higher CPAP pressures. And some people have it different at different times of the night. So the machines now will respond to people. For example, if you were on your back, sometimes you may need a little more pressure than on your side. If you're in deep sleep, you may need more pressure than light sleep. And the machines can respond really well. They also respond to people's weight changes, because I didn't mention it before, but when we gain and lose weight, the weight changes will happen often in the belly, maybe the hips, but really often in the head and neck. And some people store their weight here, which is what I do actually when I gain weight, but some people don't. But it's the people that store their weight here where changes can make a big difference. And so if people over time, they gain a few pounds, well, they'll probably need a little more pressure to keep things open. And that's what the machines can respond nicely to. And so automatically adjusting CPAP, it's very safe. It's not perfect, but it's very safe. And that's what, even though I'm a surgeon, that's what we use all the time. Now, about a third of patients don't do well with that. They're not comfortable with it. Their nose may be blocked. They just don't like the strap. They turn in their sleep. And so it's very common to have people that aren't comfortable sleeping through the night with their CPAP. So that's when I think about other options, and they fall into.
Can I interrupt you for one quick second?
Sure, yeah,
Before we leave CPAP, I want to ask a couple of questions about that, just so that because I'm going to forget, and it's going to be bad news. Sure, I'm getting to that age. So with CPAP, the first question I have is, I'm assuming it has to be prescribed by a physician. You can't just go to a store to Target and buy CPAP. Is that correct?
It's correct. You can buy it online, but you do need a prescription.
Perfect. The other question is, do guys need to be aware of any specific risks of using a CPAP machine, either in the short or long term?
I mean, nothing is without any risks at all. I mean, the main risks that people get are things like dryness of their nose, potentially a nosebleed, potentially, I'm talking about rare things that can trigger things like sinus problems. People can get ear problems, like the pressure in their ears, they can get ear pain. These are by and large very safe things for the typical patient with obstructive sleep apnea. Again, there are outliers, people with bad heart failure or something like that, but by and large, it's pretty mild. Side effects are annoying. Stop when you stop using it. And so you just want to be aware of, if you're having new problems that occur with your CPAP, well, then you would stop it and let someone know who prescribed it for you.
And if somebody not bothersome at all, I'm fine with it. It works. There's no, the durability is there that I can potentially use this for the rest of my life. I don't need to think of this as like, this is going to work for 3 years and then, then I have to switch to something else. Is that the case, or how does it work?
Yes, you would be able to keep using it. People have used it for decades. You would keep using it. You would get eligible for a new machine every 5 years. There are replacements for the tubing and the masks. All those things are supplies that wear out. And just because of, low risk of infection, if you just keep using it forever, you sort of replace them on a 3 to 6 month cycle, depending on the component. So there are some things that you need to take care of it, clean it, all that. But it's something that absolutely can use over time. And it would be a permanent thing unless something else happens. So sometimes, for example, someone's really tired and they say, oh, I've been so tired, I gained some weight. Well, I say, hey, this could be a short-term option. Use the CPAP. If you're comfortable with it, you may get energy back to be able to lose some of the weight and then make the problem go away. And it absolutely can occur, but you don't have to worry that you're making it worse or that it's not going to work forever for you by wearing CPAP. If it's comfortable, it's absolutely keep using it over time.
Makes sense. So now you were saying, okay, let's say for some reason CPAP doesn't work for you, or you just can't handle having the mask on. You said there's other options. So please go ahead with that bucket.
Sure, absolutely. So people that don't do well with CPAP, that's actually the bulk of my practice. Mm-hmm. And 2 options that exist for those patients include surgery and special mouthpieces called oral appliances. Technically, there are 2 kinds of mouthpieces. One, sort of a little bit simplistic, but it can be helpful for some people, is basically like a suction cup for your tongue. So your tongue falling back to block your breathing can be a big part of what's causing sleep apnea. So this literally is something that's like a bulb that sits outside your mouth and you stick your tongue in it. It's often uncomfortable, but it actually is certainly inexpensive and can work for some people. But the most common kind of mouthpieces that are used are more sophisticated. They have an upper part, like a retainer for your upper teeth, a lower part for the lower teeth. And basically they connect with each other in a way that pulls your lower teeth forward by holding your jaw forward. And they have their potential side effects too. They can give you issues with your TMJs or your jaw joint. They can move your teeth and change how your teeth fit together, or they can give you tooth pain. There's some other things that are less involved. Nothing life-threatening, but some people do great with those, but a lot of people we're seeing for surgery, and sometimes a combination actually of mouthpieces and surgery. Mm-hmm. And so you alluded to the fact, and I alluded to it as well, that for a long time, there was really just one main surgery for sleep apnea. And it didn't work that well.
Right.
So I think some of the big advances that have occurred with, a lot of people thinking about things and being innovative and a lot of companies being involved in developing technologies is that we don't use the same thing in everybody. And I think for a long time, people were having a cookie cutter approach. And I think that even today, a lot of people have one thing that, hey, I like to do this. And that's not my approach. It's something that's not the way life works or medical care works. You don't have a blood pressure pill for every single person with high blood pressure because it doesn't work equally well. And so really, again, the focus of my career is how do we choose different treatments for different people, and especially how we do choose different procedures for different people to try to get the results we're looking for.
Mm-hmm. So can you help us understand some of those different types of procedures and kind of maybe some of the risks and benefits of them, just to give us, I mean, obviously it's different for different people, but on a high level, at least so people can understand what they might be in for.
Sure. So the best approach, analogy, I guess, to think about surgery is surgery treats what we call anatomy, the structure. Mm-hmm. If you think about sleep apnea, it's almost like a plumbing problem, because if you had pipes in your home that the water wasn't getting to the pipes, you need to figure out where the pipe is blocked. And that's absolutely the way we approach surgery. So that the different areas where breathing passages can be blocked include the nose, the area up high in the throat, behind the soft palate, behind this back of the roof of your mouth, and then down low in your throat, basically behind your tongue. And it's more complicated than that because there are different things that can play a role in blocking breathing in these different pathways. But that's sort of the first question that you need to think about. And typically it's more than one, to be honest. That's why single procedures don't work all that great. But you figure out where's open, where's not so open. And we do different things. The nasal procedures tend to be a little less involved, a little bit easier recovery period, definitely less pain. The throat surgeries, it does hurt more because you've had surgery in your throat, and every time you swallow, and you don't realize how much you swallow until you have throat surgery, but it hurts. And we control that pain. And we treat you aggressively, and we watch you and give you strong pain medicine, and we use a lot of other tricks to try to cut down the pain. But it's painful, and so it's something that if something as simple as tonsillectomy, it's pretty significant for like a week and a half to 2 weeks. But again, the pain is managed. You get through it, and the idea is that you put up with that, 2, maybe 3 week, but really mostly 2 week recovery, and you finally get some rest. And you weren't getting with something like a CPAP machine because it wasn't comfortable. So we don't do surgery just because it's convenient. You don't have to carry around a machine if you travel or things like that. We really do it if it's not working well for you and figure out what's involved. So just to give you a little brief thing that, aerial view of the kinds of things that we look at. So for the surgery of the soft palate, often involves taking out tonsils of people that have not had them removed before. So you get a tonsillectomy in combination typically with some sort of surgery of the soft palate. The old-fashioned approach back when I was in medical school, and still, honestly, still some people are doing this, was to basically chop off the uvula, which is like the punching bag hanging out of the throat, and part of the soft palate. And that's actually what a lot of, not just surgeons, but a lot of doctors, in other fields think is sleep surgery, the only thing we have available. Yeah. It turns out that, over the last really 10 to 15 years, there have been some better techniques, and I do mean better, they work better, but also have less side effects. And the better techniques that are based not so much on just removing tissue by cutting things out, but actually on repositioning tissue, sort of moving things around. And the idea is that if you move things around, you make things more open and you stabilize them without getting some of the side effects that people would get when you were just cutting things out. And that's surgery just for up high in the throat. Now for down low in the throat, where it's not the only thing, but the tongue can fall back and block breathing. There's all sorts of things out there, from tightening up the tongue a little bit so it doesn't fall back as much, to moving the anchor point for the tongue forward, which is right here. The chin is moving the piece of bone forward. It's sort of a crazy thing, but you move the tongue forward so it doesn't fall back as easily to block your breathing. To removing part of the tongue, especially the tonsil that we actually have on the back of our tongue, sort of a different tonsil that we think about as the tonsils that get tonsillitis. But there's even a new technology. I mean, I guess not so new. It was approved in 2014 by the FDA with a lot of supportive evidence, well over 100 studies now published. But it's basically like a pacemaker for the tongue. It's a device that would go in the body. It's called upper airway stimulation, made by a company called Inspire. But all these things have technologies associated with them. And really, we can do a lot more. And it's what's made this such a great field is that we went from something where we had a couple options only, now having a few options, many options, I should say, for patients that aren't doing well with CPAP.
Well, I mean, I think that that's actually really eye-opening because, yes, as a physician, when I was in medical school, when the dinosaurs roamed the earth, it was, uvuloplasty, uvuloplasty. That's all we always thought uvula was shaking around and causing the snoring, right? But what's amazing is how scientific this field has become and how precision focused it is, meaning you're focusing on the actual problem. You're pinpointing where the problem is, and you're laser focused on that problem, whether it's in the nose or in the soft palate or in the throat or in the tongue. It's not a one size fits all. And I think that a lot of guys out there would take comfort in that it's kind of, if they're going to go through, let's say, a procedure that might be uncomfortable, at least at the end, you're hitting the right nail with the right hammer, which is great. It's definitely a different perspective than I think a lot of guys have for this.
Right. And I think honestly, I was in my fellowship learning about all these different things. So after people do their what's called residency training, they can do additional training in a fellowship. I know you know this, but as for your audience. And so I did a fellowship in sleep surgery. And I was learning about all these things, and we did our best while people were awake. But I actually heard a presentation from, again, someone who's now a pretty good friend of mine, a German surgeon, talking about this thing that we renamed drug-induced sleep endoscopy. It's something that he didn't develop it, I didn't develop it, but some of our colleagues that we work with now sort of were one of the places that helped develop it. But the idea behind it is try to get a sense of what's causing the blockage in the throat typically. And so we use these telescopes that I mentioned in the office. I joke with patients that I really want to know what's going on when you're sleeping. So we'll make an appointment, I'll come to your home and I'll sort of hover over your bed with a telescope in your nose, but nobody really wants to do that. So instead, this idea came up that, hey, why don't we get some patients some light sedation in the operating room? We do it in the operating room and have them drift off. And then we can look with a telescope in something that actually is not so different from natural sleep. Yeah, it's not the same, but it's in the neighborhood. And we do all sorts of things. We put people on their side, we roll them on their back. We sometimes lift their jaw forward, sort of reproducing what these special mouthpieces might offer. And so we get some information together to guide us. And it's one of the areas that we've done a lot of research and led some multi-center studies, meaning getting people, busy centers from around the world together to really look at how it informs how we choose procedures, number one. Number two is how we know whether to even operate and have surgery in the first place, because there's people that probably just don't do quite as well because they have something causing their sleep apnea that's maybe not as amenable to surgery. So that's really an area where we are one of the world's experts in this thing called drug-induced sleep endoscopy. And that's not everyone, but often it can be part of the evaluation process.
Well, that's fascinating way to think about it, and it makes sense. And again, I'm astounded as to the precision with which you're approaching this problem, which is again reassuring for patients. But this brings up my next question, which is there's a lot on the line here, and there's a lot of options. How does a typical guy out there who's snoring and worried about sleep apnea, who do they go see? How do they know that the person they're seeing is qualified to to evaluate them, to make those decisions, and then qualified to do these procedures? And some of them sound somewhat technical and complicated.
Yeah, I mean, I think that it's probably true, as in all areas of medicine, that the problem is often called asymmetric information, so that the doctors know more than the patients. And I don't want to inspire distrust or mistrust in the medical community, but I think it's very fair to ask for patients to ask their doctors if they treat a lot of sleep apnea and find someone that does. And it's okay. It's not something that I take as a threatening, question, and I'm not put off by it. But we just talk about, do you do this a lot? And people have areas of focus, and sometimes they do a lot of something, and sometimes they don't. And it's okay to ask that. And I mean, there are organizations. I was president of this group that's probably the main group in our field called the International Surgical Sleep Society. There's a membership, but I mean, honestly, for all these organizations, you just sort of pay a membership fee and you can join. And so that's not necessarily a quality measure. The reality is that obviously there's board certification and other kinds of things that are meant to be quality measures, and they work pretty well, but they aren't perfect. But I think the biggest thing is that someone does a lot of it. And you can ask about, what are results, and generally they should still do a lot of different things, not just one thing for everybody. And right. That's the way that I think about it, because although, there's a lot of advertising marketing for this one pacemaker device right now, and every new thing comes along and just gets marketed very heavily. And so people go from one thing to another, but having this array of options, use the hammer analogy. We don't use a sledgehammer never to put a nail in a 2x4. We want to figure out what's going to make sense for the patient. And typically, after we go through our evaluation, it'll be a discussion where you say, you've got a couple options. And
Right.
there's some pros and cons of each one. And we work together. And my job is to let people make the most informed decision. I don't let them choose their surgery. It's not like they come in and they pick.
Sure.
But this is why, and hopefully it makes sense to them. This is why we're choosing one thing versus another. Here's some of the studies, including our own work that we use to actually, these are questions that are directly important to patients and obviously surgeons as well. And we want to use the research that is available. It's not perfect. It's not, there are things we know and things we don't know. A lot of times, the way I think about it is that I don't like to do surgeries unless we have about a 70% chance at least of clearing up someone's sleep apnea. It's not 90+% always, but it's not 10% either. And that's the way we look at things. Even if we don't get those perfect results, we often make things better. And then when we don't, we say, well, why didn't we get the good results? What can we add maybe to what we've done already to, again, get the what we're looking for?
And so I want to actually dive into that for a quick second. So again, it's really hard because there's so many different procedures and different types, but on average, would you say success can be judged at around 70% is the usual?
Right. That's what we're looking for. Taking someone who's got some significant sleep apnea and getting it to a point where they don't really need to wear CPAP anymore.
Mm-hmm. Well, that's a fair judgment. And the other question is, and again,
I should mention, they weren't wearing CPAP to begin with. But if to a level that if they came in right off the bat at a certain level of sleep apnea, if they've got, for example, some mild sleep apnea that's not bothering them, the people wouldn't recommend any other treatment either. That they get it to a point where either zero sleep apnea or very mild where they don't need to worry about it.
And how, again, varies by procedure, I'm sure, but how durable are these procedures? If I get whichever one of the things you mentioned, procedures done or the pacemaker or whatnot, is that like CPAP, a lifetime type of solution, or is that things tend to move back, regrow? I'm not sure the right way to put it, but that the problem will return.
The short answer is that, like all of medicine, to be honest, most studies are relatively short term. So surgery, it's usually the 6 to 12 month range. Some treatments, one of the nice things about this technology is they've got 5-year studies, which is amazing. Mm-hmm. But it's true for all sorts of things in medicine. It's sort of, scary if you want to call it that. But the point is that I can tell you what my take on the literature is, and then my own experience. So my take on the literature, a lot of people have criticized sleep surgery because they'll say, and typically studies were done with this old-fashioned approach, that they took a bunch of patients that had this surgery and then looked at them like 10, 15 years later. And the results were pretty mediocre. Mm-hmm. The reality is, though, they didn't know if they had good results to begin with. So you probably mediocre results off the bat, and basically they didn't have good results later on. Nothing magically got better. So what we think about in my own experience and just sort of thinking about what might be happening, people get older. We all get wrinkles. Things sag a little bit on the outside and on the inside. And so that's the concern with sleep apnea is that you're creating an open throat, you hope, and you don't want the natural aging process to let things sag so you get that collapse again. And so people have worried that, it just comes back. In my experience, and really the studies that have looked at this, which are not many, weight gain is the #1 enemy of long-term results for sleep apnea surgery. And I'm not talking about like a couple of pounds, but I'm talking about like 10 or more pounds. That'll make things come back. And so, I can give you my anecdotal experience of patients send me cards every year because they say, 10 years strong, still off CPAP, but it's something that they've kept their weight down and that's why they can get good results that do persist. So it's something that I wouldn't look at this as being something that doesn't hold up, but it can. And especially, there is this tendency for us to gain, as men, to gain weight over time, probably women too. But the point is, if that happens, well, yeah, that can absolutely happen. And the mechanism, just to circle back on this theme, is this more fat in this area. There's fat actually in our tongue. It's sort of a crazy idea. It's not the fat that we see actually when someone's face gets rounder. It's actually fat in our tongue and in muscles around our throat. And right now we don't really have any way to do liposuction on that. But the point is that it's something that is probably the mechanism for how things do get worse over time is weight gain. So again, if you keep that weight off or been stable, then the benefits should hold up pretty well.
That's perfect. Dr. Kezirian, thank you so much. And that has been really, really helpful across the board. I think for the guys out there that are worried about, we're looking for a solution for snoring, or frankly, hearing about everything that's going on with sleep apnea and worrying about that. And I think you provided some great guidance for them in terms of how to approach this problem. So we thank you for that and for your time. And before we let you go, I'm going to ask you one question that I asked completely unrelated to snoring or sleep apnea, believe it or not. As a professional, as a skilled and successful surgeon, you've obviously reached a very high level of success. And one of the goals of this podcast and of our platform is really just to help men live their best lives. So I always like, in my personal life, I always like to ask successful people, what's your secret to success? Well, how do you live your best life?
Well, first of all, thank you for the opportunity to join you all, and thank you for the kind words. I think that, for all of us, it's balancing act, and sometimes I'm good at it, and sometimes I'm not so good at it. I think that, I had some nice role models, and including my own father. So just go with what, in your heart is the right thing to do. And so I have young kids now, and so you don't want them to suffer. And I think that for me, I've given up hobbies, really. I don't play golf anymore. I try to work out, but I'm not as good as I probably could be. But, it always is a trade-off. And I think it's things that I'm facing the same challenges that I'm sure all of your listeners, your audience is facing, and you just do your best. And that's, move forward.
Appreciate your humility and your candor. Dr. Kezirian, thank you so much for joining us. For all the guys out there listening and watching, thank you. And remember our motto here at Better Man Clinics: your best life is a journey and not a destination. And use every single day to just get a little bit better. We'll see you all next time.